Hello, everybody. Let me welcome you all in this Java CardioRisk wave. This is wave number 5. With me today is Professor Dr. Ahmed Shawqi from Ain Shams University, Professor Dr. Said Farag from Zagazig University. Today we'll discuss the dyslipidemia guidelines, and I think we need to discuss it again and again and again. And if you with us in the daily Ramadan quizzes on our group, it was noticed that even the simple questions about the dyslipidemia guidelines is difficult for most of us to answer. So I hope we'll answer you most of the questions, and I will leave the stage to Professor Said Farag to introduce the agenda of today's meeting. Dr. Said Farag.
Good evening, everybody. I hope that everybody, his family or beloved ones are being safe. As our dear Professor Dr. Ashraf said that we are in a dyslipidemia night. We are trying to answer a lot of practical questions through diving in recent evidences. The first part of this important webinar will be presented by Professor Ashraf Reda, a very important dive in the Dyslipidemia 2019 European Society of Cardiology, European Association of Atherosclerosis guidelines. And I think, as he said, he will answer a lot of important questions, and he will highlight very important topics in dyslipidemia. The second part of our webinar today will be presented by my brother, my colleague, the dear Professor Ahmed Shawqi. He will give us, as usual, a fantastic case, which I think also will give us a lot of practical tips and tricks in managing patients and managing high-risk patients or very high-risk patients. All of us are great to listen to him after Professor Ashraf Reda. I hope that all of you will enjoy this night, this webinar with Java CardioRisk. Please, Professor Ashraf Reda.
Thank you, Dr. Sayed. Now I will start my presentation, and I will try to concentrate on some key messages in the last dyslipidemia guidelines from the European Society of Cardiology, ES, that was announced in the last ESC meeting. Well, I will try to cover some of these important points and the key messages for it in the last guidelines. And I think the first one in the last guidelines is the new LDL goals, which is very aggressively low. And if we look at the central illustrations, and the main message from this illustration is that we are treating the risk of the patient. We are not treating the laboratory finding, not treating the LDL cholesterol level. So the main issue is we have to understand that the first step in the management of dyslipidemia is to evaluate the risk of the patient. Because according to the risk, whether it is low, moderate, high, or very high, we have a new threshold, new goals of therapy, 55 milligram per deciliter plus 50% reduction of the baseline for the very high, 70 milligram and 50% reduction in the high, 100 milligram in the moderate, and 116 milligram in the low. So this is a very aggressive numbers, and I think we need a lot of effort and a lot of drugs even to reach these numbers. I'm sorry. I'll try to المحاضرة مش عارف اطلعها ازاي تاني. Okay. Okay. We have aggressive numbers to be reached. And actually, if we look at the situation of Egypt and how we are successful in reaching specific numbers, this is a centralized CEPHEUS trial in Egypt, which was published 2014 to see how what is the percentage of goal achievement for us as a physician in our patients. And actually, it is a very disturbing numbers, because if we look at the very high risk patients, in only less than 11% of our patients are reaching the goal. And remember that that was in 2014. And the goal at that time was even higher than the goal we want to achieve this nowadays, according to the last guidelines. So if we compare ourselves in Egypt with other countries in the Middle Age, all in all, goal achievement in our patient is 32%. And as I told you in the previous slides, for the very high risk, it is only 11%. So actually, according to these new guidelines, we need a lot of effort to intensify our treatment. And that's why when these results appeared, we changed the concept of treating our patient in Egypt. And we preferred at that time using the American guidelines that start with high intensity statin therapy, regardless of the baseline, according to the risk of the patient, rather than starting with low dose and build up the dose according to the goals. The second key message is about the diabetes. Diabetes is a problem, actually, because actually not all diabetic are the same. Not all diabetic are in the same risk category and having the same LDL goal. We have to divide our diabetic patient into very high, or moderate risk. When the diabetic patient is very high, if he have target organ damage, if he has more than 3 major risk factors, or if type 1 diabetes more than 20 years, this will be diabetic with very high risk, and the goal is 50 milligram per deciliter plus 50% reduction of the baseline. However, some diabetic are at a moderate risk, and the goal may be 100. Example, young type 1 diabetes less than 35 years, type 2 diabetes less than 50 years of age, and diabetes of less than 10 years duration with no other risk factors. The high risk diabetic patient is in between those two categories. Here, diabetes more than 10 year duration with other risk factor, but without target organ damage. So diabetic actually may be in one of the 3 risk categories, and it's very important to assess the duration of the diabetes, the presence of other risk factors, and the presence of target organ damage. The only precautions in diabetic patients in which we should not use statin is the premenopausal women with diabetes, especially if they are considering pregnancy or not using adequate contraception. So it is not recommended to give the statin therapy for this patient. If we wanted to see the problem of diabetes in Egypt in patients with ischemic heart disease, we have the results of the Egyptian Cardiovascular Project published in atherosclerosis journals. And from these results, we noted that diabetes is a problem among Egyptian patients with acute coronary syndrome. 40% of Egyptian patients with acute coronary syndrome are diabetic. And actually, if we want to take an idea about the risk factor in the Egyptian with acute coronary syndrome, it depends on differ according to the gender, male or female, or according to the age. In young age, it is smoker. In the elderly, it is hypertension. In the woman, it is the metabolic syndrome and diabetes. So actually, diabetes is a great problem in our Egyptian patient with ischemic heart disease. The third point is the familial hypercholesterolemia. And actually, we thought in the past that familial hypercholesterolemia is a rare disease or it is uncommon disease. However, it seems that it is more common and more prevalent than we thought previously. That's why we should prepare ourselves to detect familial hypercholesterolemia in our patient, especially heterozygous familial hypercholesterolemia. So the questions when to expect heterozygous familial hypercholesterolemia in your patient. If you have a patient with premature atherosclerosis, less than 55 years males, less than 60 years female, consider heterozygous familial hypercholesterolemia. If the relatives of the patient, especially first-degree relatives, having premature atherosclerotic cardiovascular disease or having tendon densoma, consider heterozygous familial hypercholesterolemia. If the LDL cholesterol of your patient is very, very high, above 190 milligram in adults and or above 150 milligram in children, actually in this situation, you should consider the presence of heterozygous familial hypercholesterolemia. And believe me, this is not a rare situation. And this important paper in the atherosclerosis about the overview of the current status of familial hypercholesterolemia in over 60 countries, it was quoted in the paper, this paragraph from our data from the Egyptian Cardiorisk Project, showing that our acute coronary syndrome patients, nearly half of male and more than 60% of female are considered premature atherosclerosis, and half of them may be heterozygous familial hypercholesterolemia. So all of us should be prepared with one of the lipid scoring system to diagnose familial hypercholesterolemia. The Dutch Lipid Clinics Network score is one of them. It is very simple. You first ask about the family history. If you found in your patient a family history of premature atherosclerosis, give him 1 point. If family history with tendon-denssoma or familial hypercholesterolemia, give him 2 points. Then after the family history, the clinical history of the patient himself. If the patient himself has premature atherosclerosis, this is 2 points. If atherosclerosis in other bed prematurely, 1 point. The third step is to physically examine your patient. Tendon-denssoma 6, arcus cornealis before the age of 45 is 4 years. And this is actually the clue of the questions of Yava at Ramadan of today that will be, I think, announced with the answer now. The fourth step is to assess in the laboratory the LDL cholesterol and give the patients appropriate points. DNA analysis is not needed. So by the end of the way, you have either a definite FH, a probable FH, or a possible FH diagnosis according to the point system of your patient Dutch criteria. The third key message from the guidelines is about the acute coronary syndrome and PCI. And this is very important. Actually, acute coronary syndrome is a very serious situation. The morbidity and mortality is high. That's why we should be very serious in managing this lipidemia. The key messages regarding acute coronary syndrome, which is actually class 1 indication, is to give high potent statin therapy as early as possible on admission for patients with acute coronary syndrome, regardless of the baseline of the LDL cholesterol. And another important key message is that it is not enough to give the patient statin in the intensive care. You have to follow after discharge. 4 to 6 weeks later, you have to do lipid profile, perform lipid profile, and if not at goal, which is 55 milligram per deciliter plus 50% reduction of the baseline, you have to add another therapy, ezetimibe. And this is also not enough. You have to follow again after 4 to 6 weeks. And if it is not enough, you have to add PCSK9 inhibitor. So actually, this is the algorithm for management of patient of acute coronary syndrome. Regarding the PCI, the most important key message is whatever your PCI in acute coronary syndrome or elective PCI, you have to pre-treat the patient or load the patient with high potent statin therapy, even if the patient is on chronic statin therapy before doing your PCI. So that was the important. The last message regarding acute coronary syndrome is that sometimes in certain clinical category of patients with acute coronary syndrome, the goal is not 55 milligram. The goal is you should have less than 40 milligram per deciliter. When is that indicated? If your patients experience a second vascular event within 2 years of this event. So 2 events in 2 years means that the target is less than 40 milligram. It is not enough to have less than 50 milligram per 55. Of course, after this, the next key message will be increase the focus on the combination therapy. The goals is very low. The one drug is usually not enough, especially for the high-risk patient, to achieve 50% reduction or less than 55 milligram per deciliter. And again, if you look at our data from the CEPHEUS trial, actually 84% of our patients are on monotherapy, and the combination therapy was, a few years ago, in very small percentage of patients. That's why we have to concentrate on achieving the goals by using, don't hesitate in using combination therapy when it is indicated. And of course, the algorithm of using the combination therapy, as you know, is number one step is to assess the risk of the patient. And then put the goals for your patients, start high potent statin therapy. 4 to 6 weeks, re-evaluate. If not at goal, add ezetimibe. 4 to 6 weeks, re-evaluate. If not at goal, add PCSK9 inhibitors. But the problem here is that PCSK9, the cost is high, and the cost effectiveness should be considered, because if we apply this algorithm, we will give PCSK9 to 70 to 80% of our patients with high risk or acute coronary syndrome. That's why we have to know PCSK9 for whom, which patient should deserve PCSK9 inhibitor. It is class 1 indication to give PCSK9 for secondary prevention, patient very high risk or secondary prevention after heart attack who are not achieving the goal despite high intensity, high potent statin therapy and the combination therapy. The second indication, in which it's class 1 indication, is the familial hypercholesterolemia if they have atherosclerotic cardiovascular disease or other major risk factor. That's why we, in the IAVA, published a consensus about the use of PCSK9, which is the IAVA Egyptian PCSK9 consensus, and that was published in the atherosclerosis supplement, and it is also will be published in the next issue of the Egyptian Heart Journal. And in this article, we try to analyze the indication of PCSK9 according to. I think we can conclude that we recommend using PCSK9 inhibitor in atherosclerotic cardiovascular disease or in very high and high risk patients, not at goal with or with statin intolerance. The second indication is familial hypercholesterolemia with atherosclerotic cardiovascular disease or with additional risk factors. So cost effectiveness is an issue, of course, in Egypt and other countries. The next key message is that it is not only LDL cholesterol. There is other lipid particles that should be considered when treating patients high risk or with acute coronary syndrome or with ischemic heart disease. Okay, LDL cholesterol is the primary goal, but we have other lipids that deserve our consideration. For example, the triglyceride is important. And we were in what we call the triglyceride dilemma in the past few years. Triglyceride, we know that it is important, but we have no goals for triglyceride. We have no treatment for triglyceride. But fortunately enough, in the last few months or last year, we have the REDUCE-IT trials, which is, I think, the first trial to find a drug which is icosapent ethyl 4 capsules per day that give benefit regarding the cardiovascular endpoint when added to statin therapy in patients with hypertriglyceridemia, and this is important to solve the triglyceride dilemma. Another lipid particle that is important and should be considered lipoprotein(a), especially in those patients with premature atherosclerosis and the lipid profile is not so elevated without the criteria of familial hypercholesterolemia. So search for lipoprotein(a). And another recommendation for lipoprotein(a) is that you have to at least once in each person's lifetime to assess lipoprotein(a). If it is above 180, you have to follow these patients. So this is some lipid particles that is secondary goals of therapy. Non-HDL cholesterol is important, and it is actually the recommended levels is less than 85, less than 100, and less than 130, according to very high, and moderate risk. ApoB is another important lipoproteins because important proteins because this actually protein is very important in determining the size of the LDL particle. If you have high ApoB, that means the particle size is small, so it is an important secondary goal of therapy. As I told you, triglyceride dilemma was actually solved in these guidelines. We have now the number 150 is desirable number, and we have drugs that can treat hypertriglyceridemia. But after you give a statin and after you control the LDL cholesterol, if you still have high triglyceride, you can use omega-3 UFA to control it. So actually, regarding the triglyceride, statin, you have to say that statin treatment is recommended first drug of choice. In high-risk patient or above, triglyceride from 135 and above, you can use icosapentaethyl, and this is class 2A. 2A should be considered in the treatment. What about the elderly? Should we treat the elderly regarding lipid profile and cardiovascular prevention like the young person? Well, if your elderly patient have atherosclerotic cardiovascular disease, the young is as the old. The same applied measures, the same goals, and the same use of drugs. But you can, which is class 1 indication, it is recommended to start at low dose, especially if your patient have chronic kidney disease, have another drugs in treatment, and you are feeling of drug-drug interaction. So with atherosclerotic cardiovascular disease, young is elderly is like the young. However, for primary prevention, look at the age of the patient. If he is above 75 or less than 75. If above 75 and patient is primary prevention, treatment with a statin is recommended for primary prevention according to the level of risk in elder patient if less than 75. So less than 75, primary prevention is the same as the young, but again, start with low dose. Okay? However, if your patient is above 75, initiation of statin treatment for primary prevention is actually class 2B. So you should be considered, you should assess the risk, you should discuss with the patient, you should assess other comorbidities, other drugs, and renal function, of course. The last key message I wanted to highlight is the importance of cardiovascular image for assessment of cardio risk or atherosclerotic cardiovascular risk. And actually, there is a lot of markers now used as a risk stratifier or risk enhancer. One of them is the coronary artery calcium score, which can solve many clinical situations and can help you deciding to give lipid lowering therapy or not in some low or moderate risk patient. Another imaging like arterial, plaque burden, carotid, and femoral. So I think I tried to cover the most important key messages, and I will leave now the stage to Dr. Said Farag for some discussions about this session 1 lecture. Dr. Said Farag.
Thank you very much, Professor Ashraf, for really this very elegant and very informative lecture by diving in the guidelines and the important key messages as regard the management of the playmaker of the atherosclerosis, which is the dyslipidemia. I think he gave us a very coverable, a very informative lecture about all the key issues that we have to know. But also, I'd like to have some inquiries and some questions. One of them, Professor Ashraf, do you think that the reluctancy in doing risk scoring for our patients in our healthcare system is responsible for a lot of the for acute cardiovascular events, or it will occur whether we do risk scoring or not?
I think this is, Dr. Sayed, the most important missed issue in the management of patients with for cardiovascular prevention. Sometimes when we saw a guy who is 55 years old, he is a smoker, mild hypertension, and in good health, we think that his lipid profile is okay in the laboratory. We may think that this patient is low risk. However, if we put a 55 or 56 years, smoking, mild hypertension, whatever the total cholesterol is 200, 220, you may be surprised to find that this patient may need high-intensity statin therapy. So actually, I think risk scoring is very important. It is missing in our daily clinical management. Some of us are overconfident in assessing the patients from just some data in the history. So it's very important to calculate the risk accurately in order to do more appropriate cardiovascular prevention in our daily practice.
Actually, absolutely right point of view, Professor Ashraf, especially that, you know, from the guidelines that Egypt and some countries are classified as out of the high risk score chart. And that's why we have to upgrade one grade up for those patients at risk, not only for doing a risk scoring, but also to upgrade the risk of the patient, because we are already, as stated in the latest guideline, we are already a very high risk countries. Another point here, I just like to ask: do you think that Inclisiran, the new drug which is in the phase 3 now, will change the guideline by giving the patient a 2 injection yearly to get his or her LDL down? It will change the guideline from the clinical trials which is running now?
Well, I think the new innovations and the new modern drug therapy of lipid lowering for lipid lowering is very important. However, I think, as we discussed in the first question, that the most important is to try to assess the risk of the patient, try to use the weapons we have in our hands, because it is shame to have a high risk patient who is for years on a very low dose of statin therapy, and his LDL is 120 or 130, and nobody care and nobody try to help him. So I'm sure such treatment will be marvelous, especially if you can give one injection every 6 months or every years to get down the LDL to very, very, very low. Of course, we need years of follow-up to see the side effects and to see the efficacy and the efficacy on clinical endpoints. But for the concept of the lower is the better, we expected that these new drugs will have a marvelous effect. However, we have many weapons in our hands which we are not using properly, and we should first have to give the patient potent statin. You should have to give the patient combination therapy, and now, طبعا, of course, you have PCSK9 inhibitor that can help till these drugs will be commercially available in our country.
Again, another final and practical question, and I think you, dear Professor Ashraf, and all of the members of the IAVA are fighting this issue, which is the reformation of the lab report of the lipid profile. Because, you know, a lot of our patient is looking to his or her lab report, and it seems for him or her that his figures is within normal. That's why they took the decision to give up the treatment. And I think we have, and you will tell me, if we have to continue fighting and continue supporting the issue, that we have to reformulate the lab report in order to keep the patient compliant and sticking to the medication, which is very important, especially for those patients, very high risk and high risk patients. I need to know, again, your opinion about this point.
That's very important, actually, and I think I won't tell you that our efforts and the others have a good response in some big chains laboratory. And I noticed that in the last few years, some laboratories start to change the way they put the normal values, because, as you know, there is no normal values for the lipid. If the patient is high risk or ischemic heart disease, whatever the LDL, his LDL cholesterol is atherogenic. His lipid profile is atherogenic, even if it is low in the numbers. So they started to put a notice that the numbers is according to your risk. And this is a very important step. They have to do more than that. They have to put the goals according to each risk. For example, they have to say the very high risk 55, high risk 70, moderate risk 100, low risk 115 in their laboratory. We'll still fight. We'll try to continue our fighting
for this issue.
That issue to solve it, inshallah.
Again and again, thank you, our dear Professor Ashraf, for this elegant presentation, this also elegant responses to our comments and questions. And we will now take a break for 2 minutes. Then we will continue our YAVA night, YAVA webinar, the fifth wave, with my dear professor, my dear colleague, Professor Ahmed Shawqi. He will present for us a fantastic case related to the topic of dyslipidemia and very high-risk patients. We will back again after 2 minutes.
Okay, welcome again to the Cardio Risk Virtual Meeting Wave 5. I hope you are enjoying with us these great discussions about dyslipidemia management. And I want to welcome my friend and my colleague, Professor Dr. Ahmed Shawqi. He is Associate Secretary of the YAVA Society, and he is well known for his informative presentation and lecture, and which I usually enjoy. And I'm waiting, Ahmed, for your case discussions. So I will let the stage for you to start your case presentation to share with you an important message for the audience.
Thank you, Professor Ashraf. It's always a pleasure being with such a big authority on dyslipidemia and cardiovascular disease, not only in Egypt, but all around the world. Professor Said is a very informative, very talented professor and also a great friend. I would like to thank Ahmed and Mohammed from ICOM for their... This is going to be a case presentation. You've heard Professor Ashraf's informative lecture. He gave you a nutshell on the guidelines, which is very important. But let's take it to another step. This is a 62-year-old man. He's hypertensive, coming to you with chest pain in the ER. You do an ECG, and you find this T-wave changes in the precordial leads. There are some changes also in the inferior leads. But of course, this is probably a case of acute coronary syndrome. His blood pressure is just elevated a little bit. He has a positive troponin. So this patient is a high-risk non-STEMI. This is another point. But the question is, what is the importance of established cardiovascular disease, be it stable or chronic coronary syndrome or acute coronary syndrome? It is important that it is caused mainly in the acute part by instability and rupture of atherosclerotic plaque. And atherosclerotic plaques, whether in the heart or the brain, are the number 1 or 2 causes of death worldwide. And this is very important to take into consideration, because when we manage these diseases better, we are reducing death. Thus, we are going to improve patient outcomes. And if you look at the InterHeart study, one of the biggest epidemiological studies, the most important risk factor for myocardial infarction, if you're talking about the possibility or the odds ratio, as we say, is cholesterol, followed by smoking. So cholesterol is not something to be taken lightly. Cholesterol is extremely important and hazardous. But the question always arises. We get the patient into the CCU, we give him dual antiplatelet therapy, and you give the patient heparins. What would you give the statins or not? Some people wait. Let's wait for a lipid profile and risk stratify my patient. But Professor Ashraf just gave you the hint just a couple of minutes before. And he said, whatever the lipid profile of this patient, this LDL of this patient, and this cholesterol has caused this acute coronary syndrome. So here I have to give regardless of the lipid levels. Do I risk stratify the patient? Of course, risk stratification is extremely important. But when we stratify the risk of a patient using the score chart, as I will show you quickly, we do it for asymptomatic adults who are not with established cardiovascular disease, who are not diabetic, who are not chronic kidney disease, who are not familial hypercholesterolemia or have an LDL above 190. Don't waste your time. If this patient or that patient has any of the factors we just told you, we don't need a score chart, which you might think it's a little bit difficult. It's not so difficult, but definitely these patients are at a high risk or very high risk in most of the circumstances. And as Professor Said just told us, look at the right. Some countries like Egypt and Russia and Syria may be underestimating the risk. If we're using the very high risk chart as seen here, we are even having a higher mortality and higher complication rates because of the way we are not managing correctly. As Professor Ashraf elaborately told us, we are not giving enough high intensity statins. We're not treating the patients to the best of the guidelines. Part of the problem is because of us. And as we just said, 80% of those with an acute coronary syndrome not only have a single plaque rupture, they have multiple plaque ruptures. So again, you might have a lesion that is a culprit, and a lot of the time in the non-ST elevation MI, you might have multiple culprits, and even in the stem. And data has shown that early statin, here again, and revascularization have reduced mortality significantly. So it's not only revascularization, statins are one of the most important measures that have improved mortality in acute coronary syndromes. And if you give lipid-lowering agents, the survival rate is much better than not giving lipid-lowering agents. And if you stop patients with statins, it's much worse than if you continue on statins. The event rate, especially mortality and myocardial infarction, is reduced if you continue on the best statin therapy. So we have a very high-risk patient, not a moderate, not a high risk, not a low risk. And this is the question that we have to take into consideration. Are we giving statins immediately, very early? And even, like Professor Ashraf just told us, even in those undergoing PCI, we might reload, even in elective cases. Is it mainly for their LDL lowering capacity only, or for their other anti-inflammatory and what we call pleiotropic effect, or for both? Professor Ashraf, would you like to comment on this part, if you please?
Of course, Dr. Ahmed, I agree with you that we will give high-intensity, high-potent statin regardless of the baseline LDL and as early as possible. The importance of doing lipid profile is to know the baseline so that we can follow goal achievement, whether we can reach 50% reduction of the baseline or not after that. I think lipid lowering is very important. Pleiotropic effect is very important, but we cannot know which of which. There is many data saying that lipid lowering will not become very effective on cardiovascular endpoint in few days or few weeks. It needs some months to affect the plaque stability and to do a lipid lowering effect. However, it seemed that the explanation of the early benefit after lipid lowering therapy is mainly due to pleiotropic effect, anti-inflammatory, anti-platelet effects, anti-thrombotics, and many other pleiotropic effects. So I think both are important. Maybe B is in the early phases is more explainable, explaining the benefits than A.
Professor Said, would you like to add something? Yes, I totally agree with what Professor Ashraf said, but also I'd like to add, and this is after him actually, that the reduction in the LDL is the main source of the pleiotropic effect, because the reduction of the LDL, the reduction of the toxin, which is the LDL, there is a reduction in the inflammatory mediators. The bad guys are in the black are totally reduced with the reduction of the LDL. And this, I think, the mainstream of thinking about the pleiotropic effect by reducing the LDL, which is reducing the inflammatory pathway inside the vulnerable plaque. I think this is my comment about this point. But all in all, I think as you will choose, I think that both A and B is the right choice for this definitely practical question.
Professor Ashraf is a great, backer of pleiotropic effects, and actually the data for statins is important. Of course, LDL lowering will go with statins, ezetimibe, PCSK9 inhibitors, but look at this chart. If you look at the patients for acute chronic syndromes and those who received statins in the first day versus second or third day, this is nowhere near an LDL reduction. LDL reduction does work, definitely, but over a longer period of time. But the earlier you give high-intensity statins, you are reducing mortality and recurrent myocardial infarction because, as you said, Professor Said, of the potential other mechanism, what we call the pleiotropic effect. And this effect is not just LDL lowering, it decreases coagulation, platelet activation, improves endothelial function, and these also explain why high-dose atorvastatin, high-dose rosuvastatin can let's say, reduce the incidence of contrast-induced nephropathy in those undergoing intervention or those going PCI. So it's not just a matter of repairing the plaque and keep it stable, it's also decreasing inflammation in the acute situation. In the non-acute situation, it's a different problem. So statins here really do help. And we have other medications, but all of them have become very expensive, the antioxidants like the canakinumab. So when to start? As soon as possible. Professor Ashraf just told us the guidelines in a nutshell. It was brilliantly told. It's a class 1, high-dose statins, high-intensity statins, early after admission in all STEMI or non-STEMI. But the patient was given 80 milligrams atorvastatin. The highest dose is 80 milligrams or 40 milligrams rosuvastatin. When would you like to reassess his lipid profile again? I'm not going to ask the panel because I know they know it, and Professor Ashraf told it. Probably this should be an examination for the audience after Professor Ashraf's elaborate talk. We used to think that follow-up is like 2 to 3 months, which is 8 to 12 weeks. Actually, the newer guidelines, after giving these high-intensity statins, which are the atorva and rosuva, show that we should evaluate 4 to 6 weeks. What does this mean? This means is not to waste time. If the patient is not having a reduction that is quick and effective, we must add other medications so we can reduce more and more. So don't wait for a very long time. We can do it after 4 to 8 weeks, 6 weeks, sorry. And the important thing, you start off with the high intensity statin up to the highest tolerable dose. What does highest tolerable dose mean? Even if you start with 40 milligrams of atorvastatin and the patient, you are afraid for compliance or any other problems, you increase it to 80 milligrams before you go to ezetimibe. Why is that? Because these are the doses of statin that have shown improved mortality. Question. What is the LDL target in our patient? Professor Ashraf, I think you just elaborately told us it is now 55, it is not 70. Of course, still the American guidelines have not changed below 70, but I think they will agree with our data. Because going below 55 has shown reduction of mortality, myocardial infarction, recurrent strokes, and this is class 1. Very important to take into consideration. And it is built not just on one trial, it is multiple trials on statins and other non-statin therapies also well. So here, here I cannot stress as much. This has been highlighted to me by Professor Said so many times. 2016, they said we go below 70. And if the patient is from 70 to 135, you can go for a 50% reduction. That means you can go to 35. But in 2019, you go below 55 and 50% reduction. That is to say, if your patient has a starting of 60, you go to 30 or even less if you need it. Another question. Our patient took atorvastatin 80 milligrams. He was given ezetimibe, all according to the guidelines that were brilliantly told to us by Professor Ashraf. His LDL is not at goal, it's 84. What is the next step? Because I think this is a dilemma a lot of us see. Professor Ashraf, what would you like? Just wait, give a fibrate, change the statin to another statin, add polyunsaturated fatty acid, or here in an acute chronic syndrome, maybe add a PCSK9 inhibitor?
Well, I think, Ahmed, if I don't care about the cost, I will add PCSK9 inhibitor.
Okay.
The guidelines tell us to add ezetimibe. But I think adding ezetimibe, I will not expect to get the LDL from 84 to 55 with adding ezetimibe. However, it should be tried first.
He's on ezetimibe. He's now also on ezetimibe. Okay, I'm sorry.
He's already on ezetimibe. I think if the cost is not an issue, of course, we'll add PCSK9. If the cost is an issue, I will try another statin with ezetimibe.
Professor Said, would you like to add something here, or?
I think the guideline here is very clear that if we not reach the target in this particular patient, which is or who is a very high risk patient, we are obliged to add the PCSK9 inhibitor. But as Professor Ashraf said, sometimes the cost will be an obstacle for us to do. But the evidence here is clear for this particular patient is to add PCSK9 inhibitor. It is class 1 level of evidence A.
Well, we do have a lot of LDL lowering medications, and problem is some of them are cheap, some of them are very expensive, like the PCSK9 inhibitors, those that decrease LDL production, like the MTP inhibitors or the ApoB antisense. Also, the inclisiran may be a little bit cheaper as they are projecting than PCSK, but of course, still very expensive. So we're waiting to see what this is. But according to the guidelines, like Professor Said just told us, it is class 1. In an acute coronary syndrome, 4 to 6 weeks after high-intensity statin, you add ezetimibe. 4 to 6 weeks after ezetimibe, you add a PCSK if the patient can, of course, and his insurance can take. This is class 1. And again, I remind you, Professor Ashraf's elegant lecture, in primary prevention, PCSK9 inhibitors are class 2B. Again, the Europeans are trying also to analyze the cost effectiveness because this medication is quite expensive and should be taken into consideration in the highest of patients. Again, in the guidelines, in the United States guidelines, it's class 1 for secondary prevention or very high risk patients. But in those which are not established or in acute coronary syndrome, they go lower down with the risk. Ezetimibe just works in a different mechanisms. It inhibits the absorption of cholesterol in the small intestine by different mechanisms. But PCSK9 inhibitors do a different thing. They improve quickly to say the LDL receptor recycling, which is inhibited by a molecule called PCSK9. So the inhibitors inhibit the PCSK9, and thus the LDL recycles the receptor up so it can clear the extra cholesterol from the bloodstream. And actually adding a PCSK9 inhibitor to a high-intensity statin and ezetimibe can even reduce the LDL by 85%. And sometimes we need these. Of course, if PCSK9 inhibitors, like Professor Ashraf said, were cheap and easy to use and easy, from the cost problem, they will be probably used in more than 70%. But the problem right now worldwide is the cost. Of course, this is a question I will go very quickly. What are the ones that are used? Of course, all three are PCSK9 inhibitors, but only A and B have the data to show this. The alirocumab and evolocumab. Boxuzumab has been stopped because of its immunogenicity. But I have a question, and Professor Ashraf passed it very quickly, and it was there. Say, Professor Ashraf, this patient should have another acute coronary syndrome, even of its medications. Do you think we should change his LDL targets from 55 to lower? Is there evidence for that? Or in the guidelines, they don't state anything about that?
No, in the guidelines, they really pointed out these situations. If the patient has another acute coronary syndrome within 2 years, 2 attacks in 2 years.
Yes.
Of course, the first step is to go to 55. Because this is not easy for your patients.
Yes.
And after going to 55, it should be, according to the guidelines, to go to less than 40 milligram per deciliter, if you can, of course.
Professor Said, would you like to add something?
Yes, I'd like to add something, but it is regarding the previous point, because it is very practical, actually. As Professor Ashraf mentioned, which is a real problem already, which is the problem of the cost for the PCSK9. For those patients who cannot be able to achieve the target with the high-intensity statin and with adding ezetimibe, I think there is something or the forgotten issue, which is the general measures. Sometimes the patients want to eat whatever he would like to eat with a sedentary life, without walking, and wants his LDL to be target, and he has no enough money to be on PCSK9. So we have now the option, which is tough, but it is cheap, of course, is to follow the general measures beside the high-intensity statin and the ezetimibe, because most of the patients are omitting this issue, which is the general measures. So there is something also to correct, that the guideline is a class 1, but level of evidence B, because it is based on one single trial, which is the Odyssey outcome trial, which is a trial done for those patients with acute coronary syndrome.
Thank you so much. Again, thank you for this input. Yes, lifestyle modification, which was not highlighted in this patient, should go for any dyslipidemic patient, any hypertensive patient, any diabetic patient. Yes, this is probably one of the biggest problems we face in Egypt. And thank you, Professor Said, for highlighting this, and Professor Ashraf for telling us. Yes, in the guidelines, like Professor Ashraf said, in certain cases, if you have another or a recurrent vascular event, whether it's in the heart or the brain or whenever, yes, sometimes you can go for an LDL goal of 1 millimole, which is considered 40 milligrams. This can be considered. Of course, going lower is better. Going lower is better because actually it's not a J curve. It looks like a linear curve. The lower the LDL, the better. What is very low LDL? I think till now we don't have an answer to that. And what is hazardous as a low LDL? I don't think we have. So to take home our messages, risk stratification is very important. You don't have to risk stratify diabetic, established cardiovascular disease. You have to stratify those which are at moderate or low risk. And Professor Ashraf said, a lot of them might even be high or very high if you do not take into consideration. Acute coronary syndrome is important as the number 1 cause of death in the world. And if we are not properly managing it, we are increasing death. And one of the most important reduction of death is statins and better interventional management. So this is important. Statins in primary prevention, very important. Secondary prevention, very important. The targets, as Professor Ashraf showed us, and the guidelines are showing us, are going lower and lower. Why? Because there is no hazard from going lower, and there is also an increase in better outcomes for our patients. So try and get to the guideline recommended. We are not going to do everything 100%, but if we are trying better and better, we might reduce cardiovascular events. And thinking of combination therapy with ezetimibe and sometimes PCSK9 inhibitors, if we require them, might help save some patients. Thank you so much.
Thank you very much, Professor Ahmed. As usual, very elegant presentation, very illustrative for a very important everyday practice case of very high risk ACS case, not reaching the goal, what to do, what are the tips and tricks when you are managing these patients. You tackle all the points, you cover all the points very elegantly. I think I have one more question, which I think also is practical, and it is asked a lot by our fellows. How low should we go? Because sometimes in the era of the PCSK9, in the era of the high-intensity statin, in the era of the combination therapy, now we can find an LDL of 15 sometimes, LDL of 10 sometimes. Do you think we have a cutoff value? We have a cutoff figure to reach?
Very good question. Very important, yes. If you look at the guidelines for hypertension, they say go below 130 or 140, but don't go below 120, don't go below 70. If you look at diabetes, don't go below 6.5 if the patient has established cardiovascular disease, or don't go below for avoidance of hypoglycemia effects. But in the guidelines for dyslipidemia, whether American or European, there is no low. Not to say go to 0, I don't know. But we have safety data, definite safety data coming from evolocumab, that going lower to 10 is safe, is doable, and comparing it to 100 milligrams, of course, efficacy 10 is much better for reducing myocardial infarction, strokes, and death. but there was no increase in problem of cognitive outcomes or any other problems related to the body.
Great. I think we cover most of the points in the dyslipidemia practical issues in the presentation of our dear professor, Professor Ashraf Reda. And the mission, I think, was accomplished by the great case presentation by my dear colleague and brother, Professor Ahmed Shawqi. I don't know, I would like Professor Ashraf to conclude this very fantastic night. Professor Ashraf? Okay, I think after this very fantastic IAVA night, if I'd like to say, with my dear professor, Professor Ashraf Reda, the president of IAVA, and my dear colleague and brother, Professor Ahmed Shawqi, the associate secretary of IAVA, I hope that we cover and present important points in dyslipidemia and the case presentation also in a high or a very high risk patient. And we hope also for all of you, your families, your beloved ones to be safe and to meet again in our IAVA webinars. Thank you again for your attendance. Thank you, ICOM, for your technical support. Ahmed, Adil, Ahmed Yusri, thank you very much. And let's meet again so soon, inshallah.